Major funding for these broadcasts has been provided by grants from New York Community Bank, Capital One Bank, Eastern Consolidated, M&T Bank, Sterling National Bank, Meridian Capital Group, Customers Bank, Aerial Property Advisors, Dime Community Bank, Perfect Building Maintenance. Additional funding has been provided by AKA Hotels Corman Communities, AmTrust Title Insurance Company, AVR Realty Company, Avison Young, Bank of America, Merrill Lynch, Bank Leumi USA, Briarwood Organization, CBRE, Chase Commercial Term Lending, Chase Mortgage Lending, J.P. Morgan Chase, Citizens Bank, Cohen Equities, Colliers International NYC, Collins Building Services, Connect One Bank, CPEX Real Estate Services, Douglaston Development, Levine Builders, Flushing Bank, Friedman LLP, Handler Real Estate Organization, Handro Properties, Hodges Ward Elliott, Inc., Investors Bank, James D. Kuhn Real Estate Center at Syracuse University, Kilroy Architectural Windows, Madison Realty Capital, Matone Group, Mercantile Bank, New Banks, Newmark Knight Frank, Optimum Window Manufacturing Corp., People's United Bank, Pulcinelli, Rockefeller Group, Rosewood Realty Services, SJP Properties, Stonehenge Partners, TD Bank, Terra CRG, the Knackle Group at Cushman & Wakefield, the Meringoff Family Foundation, the Moynihan Group, and these friends.
We are on the second part of the discussion of the epidemic on the opioids. So I'd like my guests to reintroduce themselves.
Elaine Pozicki, and I am co-chair of the Partnership for Drug-Free New Jersey. And my husband Steve and I started a nonprofit called Prevent Opiate Abuse. And we also lost our son to opioids, and thus our involvement and our understanding of the dangers of opiate prescribing practices in the United States.
My name is Andrew Kolodny. I'm the Director of Physicians for Responsible Opioid Prescribing, and I'm co-director of the Opioid Policy Research Collaborative at Brandeis University.
Hi, my name is Joe Coronado. I'm the Ocean County Prosecutor.
Angelo Valente, I'm the Executive Director of the Partnership for a Drug-Free New Jersey.
Steve Witkoff, and I lost my son Andrew Witkoff to an opioid overdose August 14th, 2011.
You lost your son on that date, but it was due to the fact that he was able to get drugs over the internet. In researching this show, I was able to see, it was like going to Amazon.com, looking at different products, grading the heroin or the drugs or the Oxycontin. How did your son get the drugs?
My son went on an internet site owned by the way, an internet site owned by 3 major corporations, protected by the Internet Communications Act, was put together with a dealer who we found out.
Was it an open site that somebody?
Open site, put together with a dealer who we found out had done over 1,000 transactions on the site. Met him in a parking lot, bought the drugs, and this drug dealer, by the way, was sentenced. He was doing 8 years in a federal prison. The website that connected them, and they were connected on that website, is immune from prosecution. under our current legislation, which is a pretty large problem, because many people think that people buying opiate opiate abusers simply get it from a doctor, and that's just not the case. I mean, you can actually dial up on your mobile device and you can make a transaction right then and there. And again, this is not the dark web. This is the regular way that people access websites.
Have you prosecuted?
Yeah, Steve is absolutely correct. I mean, you don't have to go to the dark web, you can go to the deep web, but you can certainly order up your drugs. People think that the web really only is here in the United States, but it's all over the world. So you can order your drugs from Russia, from India, from China, and you can have your local postal authorities, FedEx, UPS, DHL, they'll deliver it right to your door. So the bottom line is it's a challenge for law enforcement right now, because it's not coming necessarily by land.
So how do we restrict this?
It's very difficult. It's very difficult. I mean, it's a challenge. I think that's one reason why I think the DEA and the federal government are looking to negotiate with the other countries to kind of restrict the access to their pills and to their heroin and to their fentanyl. But the bottom line is that a lot of these other countries don't have the regulations that we have here in the United States, and it's very easy, unfortunately, to be able to order up over the internet, just like Steve said did, unfortunately.
So how do you, in your role, educate parents, children, to the problems, the potential risks of opioid? Because I think one of the things on your site said that parents don't want to talk to their children about potential drug problems. Okay, a 13-year-old doesn't want to sit down with you to talk about, there is a potential risk. Oh, my kid's fine, but in reality, we're finding out that the opioid deaths are young and old.
Absolutely.
It's not in the middle class.
Well, first and foremost, we encourage all families to be as diligent as possible and have those conversations with their children at a very young age, and obviously age appropriate, but continue those conversations into teenage years and then even past that point, because even when a child goes on to college, certainly they need to get the support and encouragement of their families, and you want to continue that communications. The second thing that we found to be effective is to get the message out through the media. We're working with television, radio stations, print media, electronic media, billboards that we have right now in Times Square. And our message is really simple. Our message is, would you give your child heroin for a broken limb? Or would you give your child heroin for a wisdom tooth extraction? Because in effect, that's what's happening. When somebody's being prescribed these medications, in many cases, these medications are leading to heroin abuse. And there are many of the same compounds between a prescription opioid and heroin. So we need to be able to stop it at the source.
So how do we stop the drug companies from distributing this product so well? Okay?
Well,
Purdue Pharma is not going out of business.
Yeah, so
Johnson & Johnson is not going.
Yeah, doctors have to prescribe them, and I think the work that Angelo and Elaine have been doing and the messages that they're trying to get out are exactly what we need. The focus on getting to the medical community, the Do No Harm symposiums that they've been sponsoring to reach prescribers, and the social marketing that they're doing to educate both the public and the medical community that prescription opioids are essentially heroin pills. Drugs like hydrocodone and oxycodone. Hydrocodone is in Vicodin, oxycodone is in OxyContin. To make them, you literally start with opium. And in fact, J&J has been producing much of the opium. They grow the legal poppies to make these narcotics. The effects that hydrocodone and oxycodone produce in the brain are indistinguishable from the effects produced by heroin. An experienced heroin user, and this was a study done at Columbia University where they took experienced heroin users and allowed them to self-administer oxycodone, heroin, or some other opioid. They didn't tell them which was which. And then they asked them to rate the effects. In that study, the heroin users actually, it was like a blind taste test. The heroin users actually preferred the oxycodone to heroin. So I think these messages that they're trying to communicate are exactly what we need, because as we talked about last week, young people do try and make choices or try and estimate risk when they're experimenting with
What
drugs, and they
what-
don't know that these are heroin pills.
Okay, what percentage of these overdoses, okay, in the studies that you've been doing, are kids from the suburbs? The overdoses, there is overdoses, but that's one market. We are seeing an overdose in a educated, higher income category suburban market than we've ever seen before. And the numbers go up each and every day. They don't decrease. How can you stop it?
Well, like I said, I think it's the attack of the family unit. When we really talk about the parents don't talk at the dinner table anymore. The father's taking the one child to the basketball game. The mother's taking the child to cheerleading. They don't talk. And when they do sit at the dinner table, unfortunately now I think they all are there with their cell phones and are texting. And the fact is there's no communication within the family. So I don't think the parents really see what's going on. They become isolated. And I think that the kids, the children, there's not a drug dealer that's selling them these drugs, okay? This is not somebody who has a hood that's down at a ball field someplace that's selling them. It's their best friend. It's somebody who they know, who they rely on, says that this is not a big deal, and they get caught up on it. And I think that for me, from the law enforcement standpoint, I've broken it down into 3 blocks. One is the prevention and education block. The second block is the strong law enforcement block. And the third block is partnering up with healthcare to break the cycle of addiction. And if you work on all 3 blocks, not focus just on one, but work on all 3 blocks, you have a shot.
You know, I've been involved with healthcare screenings for many years, and there are Jewish genetic diseases, and unfortunately, there's this ultra-Orthodox group who they test for a certain amount of diseases, but they tell you that you can or you cannot get married to the person. They don't talk about the conditions. So, but what I'm saying to you is, with regard to just testing over there, if you educate the market, how about going to the members of the clergy, okay, who have a relationship with the family unit, speaking to the clergy, both the rabbis, the priests, the ministers over there, because they have I did a life story recently of a Monsignor Jamie. Everybody knows him in the community. So and he's now in Williamsburg. He's with that hip population. He's trying to do it. How do you get that? How do you get this to the unions?
You know,
okay, you remember there's this article about the Teamsters. They've seen deaths in their membership. Okay, how do you get this?
You know, Michael, if you go, I don't know, Elaine, if you ever went to the Al-Anon meetings, but if you go to an Al-Anon meeting, which is the meetings for the parents, family, and friends of people who have died, it's invariably the same story each and every time. You have families that love their children, were there for them, were desperate. The children, generally the kids, like my son Andrew, were humiliated by the use. Didn't want to admit it because they felt that they were destroying the family. They got deeper into it. They're not getting high from it. It's just maintenance at that point. And they went into it in some respects like Elaine's child, where they had an injury, and in some respects where my son Andrew, his entryway into it was he thought he was going to have some fun. Maybe there was a girl involved, I'm not sure, but the fact is, there needs to be an outcry out there about what is leading to this problem. It's an internet problem. By the way, we don't have the proper drug abuse facilities to service all of the people out there. If kids like my child, and my child was my prince. I mean, he was my life. I wear his ring, I wear his watch, he lives inside of me. I'm sure Elaine's child was just like that. If I have resources and I love my son, that was not a tough love family. I was there at every rehab facility he went to. If I lost my child, can you just imagine, by the way, what it's like for working class families who can't afford rehabs, can't go to doctors, can't get to psychologists and so forth? This is as bad a problem as exists in the United States of America today.
I think that we really need to educate parents also, because I wasn't aware of how bad the opioids are on your system and for becoming addicted. I had no idea that he was becoming addicted even after 5 days, and he was on it for 6 weeks. So when we're talking about, there's also signs and symptoms that I believe that we need to be getting out to the public, that when I look back, I realized, he was wearing long sleeves. He was not answering his phone. He wasn't calling us back. He was tired looking, disheveled. There were so many signs that I missed that I believe, we have this on the website for Drug Free New Jersey, but what we need to do is get out to the PTAs to teach the parents about the opioids, because I didn't know. I even picked up a prescription for my son, which I look back and I just can't believe I did that, but I had no idea that they were addicting.
What are we doing to the pharmaceutical companies? Okay? It's not 1997 when OxyContin came out. It's 2017. It's 20 years later where we do have this epidemic. Are they, when I was with Elaine, I said, this is just like tobacco. The tobacco companies always knew about this.
Absolutely.
This is identical to tobacco. Every one of these drug companies who are making it knows about it. Okay? Fine. They may not be the one who eventually kills the person, because the heroin will kill them, which they don't sell. But it's the drug company. It's just as bad as the tobacco company.
I mean, if Pablo Escobar would have gotten on TV, held a press conference and said, I think everyone's got it wrong, cocaine's a good drug, would anyone have accepted that logic? Of course not. But now you have drug companies who drape themselves in legitimacy, put out, as we discussed, false advertising about how fast the addictive properties of these drugs work, and nobody says a thing. There's not a public outcry.
We have hospitals who've been prescribing these because they get paid higher fees.
No, I think the hospital grades, what you're really referring to, Michael, is that the hospital grades came in and they would grade the hospitals based on the fact of, was your pain adequately addressed, and have they continued to address your pain, and after you've been released from the hospital, are they continuing to address your pain? And that's how the hospital grading took place years ago. The fact is that we didn't get into this problem just in the last 5 or 6 years. This is something that has been developing for 20 or 30 years, and it's now just escalated to such an epidemic proportion that we need to really sit down and re-look as to where we're going and what we need to do about it.
It's like in Ebola. It's just it's not ceasing. It's just continuing. It's harboring.
But there are steps that are being taken. I mean, there's a legislative package that was passed in New Jersey that now requires that a physician or a dentist has to have a conversation with the patient or the parent of a patient about the addictive qualities of those drugs. We know for sure, as a result of this law, that information will be disseminated at the time of first prescribing. So that's crucial, that parents will become knowledgeable about the addictive qualities of these drugs, because so many people have complete faith in their physician, and if they were given a 30-day supply, even if it was for a child, they think the physician, obviously, his recommendation is what they should follow, and in many cases it wasn't necessary. We know the CDC now says 3 days, maybe 5 days supply at most. The other thing that's happening is hospitals are reacting in some ways in a very positive way. St. Joseph's Hospital in Paterson became the first hospital in the country to eliminate opiate prescribing, for the most part, in their emergency rooms for most of the patients that are coming into their emergency rooms. And we see other hospitals now that are looking at this particular program called ALTO as a model program. So I think we should be looking
at... But what's happening with serious surgeries that are taking place, Well,
opioids are essential medicines for end-of-life care, palliative care, patients who may have cancer, metastatic cancer, and they play an important role when used on a short-term basis, for example, after major surgery. For minor surgical procedures, sometimes you don't need to give any opioids. If you do need to give an opioid, 3 days, as Angela mentioned, is usually more than enough. For patients who do need opioids, there is access. Unfortunately, the bulk of the prescribing, the bulk of the consumption in the United States is not end-of-life care or a few days after major surgery. The bulk of the prescribing is for common chronic conditions. It's for conditions like low back pain, chronic headache, fibromyalgia, conditions where the leading experts are very clear that we shouldn't be using opioids, and yet that accounts for the bulk of the market. And those are the conditions that opioid manufacturers are promoting their drugs for.
Recently in New Jersey, they limited to a 5-day supply when the first prescribing, and that is because when you go to the 6th day, it jumps up the addiction level. So when you prescribe a 6th day or 7th day, the addiction level really goes off the
So here's a question.
Scale.
You learn that the person is addicted, okay? You're someone to a rehab center. How do you take care of this? Because not everybody has the financial means to send somebody to a rehab center, okay? I know there's a methadone maintenance center on 125th Street off Lexington Avenue. People are petrified walking on that street over there because half of them are strung out from the methadone.
What you really need to do is, and what we've done here in Ocean County, is the fact is that you can walk into a police station now and there'll be no charges, and we'll get you into a program. But you need to have a clinical analysis. That person has to be, a clinician needs to look at, because usually not only is substance abuse, there's probably a mental health issue as a result of it. And that person usually has to be brought to a detox facility. Once that person goes through detox, whether it's 48 hours or up to a week, then you find the right type of treatment plan that that person has. And then after they've completed that treatment plan, there may be sober living, or there may be a halfway house that they need to be able to go to. But you need to have somebody who's not only going to do a clinical analysis, but is going to be like a navigator who's going to follow that person all the way through.
So it's like it's like the patient advocate.
Absolutely. Continuum of care needs to be going on. If you have that personal contact as you go through, I think you have a much better outcome.
But each time you bring up an issue, there's another subject. We could sit here for hundreds of hours and discuss this. And on this particular topic, there is no protocol for rehab afterwards. So Joe is talking about a protocol in New Jersey, one of the few states that is ahead of the curve in the
right. They're very progressive on it.
But when my son first went to rehab, I didn't know what the difference between one rehab place and another rehab place. We went because we were recommended. Some are better than others. It's impossible to get information from them. They are enormously expensive. There is an incentive to keep kids in these facilities and
recycle them.
And recycle them and not do it. The recidivist rate is incredible. I mean, when I first went there, they told me the cure rate was 12%. I couldn't believe it. I remember my son saying to me, "Dad, they're all addicts here, I'm not." And I believed him. Who doesn't want to believe their own child? But you really almost have no guidance when you walk into these.
Yeah. There's no accountability for that either. What I'm interested is outcomes, success stories. To me, we need to push that. And I think Steve hit the nail on the head. We could talk for hours on this because each block has its own problem and own issue that needs to be clarified. That's why it's not going to be a magic wand that's going to solve this problem.
Rehab stays and detox, or sometimes detox and a rehab stay, don't work well for most people who are opioid addicted. And we have middle-class families, working-class families emptying out their bank accounts to send a loved one to a 28-day rehab. Their loved one comes back, and within a week they've relapsed. It really isn't the right model. The correct model for treating opioid addiction is long-term outpatient care, and one of the treatments that does have good effectiveness for most people who are opioid addicted, more than half of patients treated with it do well, is a medicine called buprenorphine. It's got another name, Suboxone. It doesn't work great for everybody at first. In fact, many young people who are opioid addicted, the first year they come on and off it. Sometimes they trade it. They don't do great at first. But patients who stick with it do have often very good long-term outcomes, and there is inadequate access to that treatment. To prescribe OxyContin, any doctor can do it. There's no limit on the number of patients you can prescribe it to. There's no special training requirement. To treat opioid addiction with buprenorphine, there are many different restrictions, so we don't have enough patients receiving a treatment that could save their life.
How are you
And,
getting?
and there's three different types. You got methadone, then you have Suboxone, and then you also have Vivitrol. You have to understand how Narcan, but Vivitrol is the latest drug to come out, which really kind of blocks it from the neuroreceptors. It's a form of Narcan, and I think that also has a lot of promise.
Vivitrol, there was actually just an article in the New York Times about Vivitrol yesterday, and Vivitrol is a controversial treatment. Within the criminal justice system, it's very popular because there's a stigma against using treatments like buprenorphine or methadone maintenance, which you do need for some people with more severe addiction. Vivitrol is a monthly blocker, and if you get your injection and then you use another opioid, you can't feel the other opioid. And I'd have to say, if my family member was affected, or if I was addicted and I was just reading about the pros and cons of buprenorphine, methadone, Vivitrol, I would probably say Vivitrol sounds like the best option, but the evidence supporting its use is very weak. You see that about 90% of patients will drop out, and if you miss your monthly injection, the drug itself actually makes you super sensitive to opiates. So if you pick up again and you didn't get your injection, even a small dose can cause a death. So it's not really a good medicine for patients, I think, with severe opioid addiction or heroin injectors. People with mild opioid addiction, and you don't want to get them stuck on buprenorphine or methadone, it's worth a shot, but not for people with moderate to severe opioid addiction.
The key here, though, is no matter whether it's methadone, Suboxone, or Vivitrol, they need to be weaned off.
I agree.
And that's the key.
But with like a minute left, what do we want to say to my audience? What can we do immediately today to partially stem? Okay, it's this Ebola. We're not going to get rid of it. It's not overnight.
Well, Ebola is actually a pretty good analogy, because if you think about what you would do, let's say someone put you in charge of responding to an Ebola outbreak in your community. If you stopped and you thought about what you needed to do about it for just 10 minutes, you'd, I think, come up with the two primary strategies for controlling the Ebola outbreak. There are two things you'd come up with. The first thing you would come up with is we need to contain it, meaning we need to prevent new people from getting the Ebola infection, so prevent new cases of the disease.
Right.
And the second thing that you would do about the Ebola outbreak is, for everybody who's got the infection, let's get them the medical treatment they need so that they don't die from it. That's basically what we need to do about our opioid addiction epidemic. We have to prevent new people from getting addicted, and more than anything else, that boils down to getting doctors and dentists and nurse practitioners to prescribe much more cautiously so that we don't directly addict patients or indirectly cause addiction. And we have to see that for the millions of people who are addicted, that they get the right treatment. And what's most easily available to people, which is detox and rehab, doesn't work for most people with opioid addiction.
I hope to continue this topic during the season and later on. I'd like to thank Elaine, Dr. Kolodny, Joe, Angelo, and Steve, and I'll see you next week.